So last but certainly not least, I'm excited to introduce our fourth panel of the day, focused on empirical health law. This panel is going to be moderated by Dennis Langer. Dennis has been director, chairman, co-founder, and or CEO of various public and private biotech, specialty pharma, and diagnostic companies with extensive pharmaceutical company background. Under his leadership, more than 60 products were developed or commercialized. His current board memberships include Myriad Genetics, Dicerna Pharmaceuticals, Delcath Systems, Light Sciences Oncology, Sensillio Pharmaceuticals, Engene, and Alzion. Dennis is also a clinical professor in the Department of Psychiatry at the Georgetown University School of Medicine. Previously, he was chief resident in psychiatry at the Yale University School of Medicine and held clinical fellowships at Harvard Medical School and the National Institutes of Health. Dennis serves on the Committee on Medical Center Affairs of the Board of Directors of Georgetown University and is a member of the Dean's Advisory Board at Harvard Law School. He earned his BA from Columbia University, his MD at Georgetown, and his JD here at Harvard Law School. Take it away, Dennis.
I've been excited about this topic since I was first asked to moderate, because the question of whether laws designed to enhance access, affordability, cost, or appropriate utilization are one of the most important political questions of our time. And what we hope to do is have the panel illuminate why empiric techniques can provide important insights to answering these important yet very complex questions. So our goal is to provide some answers to how legal scholars approach these questions and to discuss the framework that they and their colleagues utilize. So essentially, they assess whether a law intended to be a good law is actually a good law, and if not, what needs to be done in order to make it a good law. So our agenda, as you know, is to spend the first third discussing a general question, which is what is empiric health law and how do these scholars conduct empiric health law. And then the second part will be a description of the research that they do and also what type of research they and their colleagues focus on. And then the third is we'll have ample time for interaction with the panel through your questions. So we're very lucky to have some of the leading scholars in this field, and all of these professors have had strong ties with the Petrie Flom Center, either as student fellows or academic fellows. So in alphabetical order, our panel is Michael Frakes, as Associate Professor of Law at Northwestern University Pritzker School of Law. And his research includes projects on how certain legal and financial incentives affect decisions of physicians and other healthcare providers, and also on the relationship of the financing of the US Patent and Trademark Office and how that affects key aspects of their decision-making. Rebecca Haffajee, who's the third, she recently accepted an assistant professor faculty position at the University of Michigan School of Public Health, Health Management and Policy Department, and will be teaching health law and also conducting empirical research with colleagues across the university. So congratulations to Rebecca, who's currently a fellow in pharmaceutical policy research in the Department of Population Medicine at Harvard Pilgrim Healthcare Institute. And her work combines legal and detailed empirical analyses of questions around the effects of the Federal Mental Health Parity and Equity Addiction Act and the impacts of state prescription drug monitoring program mandates. Christopher Robertson, at the end, is Professor and Associate Dean of Research and Innovation at the University of Arizona Rogers College of Law. And his research focuses on how the law can improve decisions by individuals and institutions, attending to information limits, conflicting interests, and cognitive biases, especially in the domain of healthcare. And Catherine Zeiler, in the middle, is Professor of Law and Nancy Barton Scholar at Boston University School of Law. And her work applies economic theory and empirical methods to the study of legal issues and research questions, including the impact of state legislative tort damages caps on the price of medical malpractice insurance, and the impact of hospital communications and resolution programs to resolve medical malpractice claims, and the role of medical malpractice insurers in patient safety. So with that introduction to this esteemed panel, why don't we start with some questions around empiric healthcare law. And since Kathy Zeiler was presented last, I wanted to start with her first, but also because when I do a panel like this, one of the things I often do is look for a great review article on the topic. And I did find a great review article on the topic, and it turns out to be co-authored by Michelle Mello and Kathy Zeiler, and it's called Empirical Health Law Scholarship, which was in the Georgetown Law Journal in 2008. And I would really recommend that for any of you that wants to learn more about this field. So Kathy, why don't you start in what is empiric health law to you?
Thank you. I want to start by thanking Glenn and Holly for putting together this great conference and for inviting me to participate on this fantastic panel. I define empirical health law very broadly. So usually when we think of empirical work, we think of quantitative work. We think of numbers, boiling things down to numbers. But the data we use can also be quantitative or qualitative. And we've actually learned how to take qualitative data and make it quantitative. So it's really a wide array of employing data of lots of different sorts. And the research that we do hopefully helps us to learn something new about something that we care about. So it can be, as was alluded to, the effects of law and policy on outcomes we care about, which can be health outcomes, they can be access issues, cost of healthcare, the quality of healthcare that we receive, but also in the opposite direction. So people have been studying the impacts of different features of the markets on law, how law comes to look the way it does. And so it actually, the research goes in both directions, trying to explain outcomes that we see that are produced by law, variations in law, and also how those variations in markets or outcomes impact law itself. So I would define the research very broadly to be over-inclusive if we're going to go in any direction to error.
Rebecca, you might go next because your training is in a little different approach in epidemiology and statistics and public health, and how you apply that to laws, and maybe talk a little about how you view empiric healthcare law.
Sure. So sort of the methods in the field, or
what is empiric healthcare law to you, and
yeah.
What do people like you try to do?
So I would. This is on. Okay. I would define it broadly, similar to Kathy's, and I defer to her because she's wrote the seminal article on the topic. But thinking about quantitative and qualitative methods, I have focused personally on more the quantitative methods in my work, and so sought to get some statistical and research design training specifically so that I could tackle this question. And so I view it as, and it's interesting, Kathy raised the issue of thinking about ways in which the market or policy environment affect laws. I guess I think of it more as laws and what impacts they have on health outcomes or other outcomes we care about. But I view laws quite broadly. So some might be, and this is kind of public health law research terminology, some might be interventional, and these are laws that are actually intended to impact health outcomes. Some might be infrastructural, and so they actually impact health agencies and the ways that we actually deliver health care and govern it. Others might be incidental, and this is really actually where some of the field is moving, is towards sort of social determinants of health and how housing laws might actually affect somebody's health and things like that. So, so I actually view the laws, and then it's sort of laws plus, policies more broadly. And so some of what I'm interested in is actually program evaluation, where it might be a policy that an insurer has actually implemented that to me is very analogous to a law. So I think that broad interpretation is how I would view the field. And then I can talk more later about the methods that I've used, but have been really interested in applying quantitative methods. But increasingly, I'm actually interested in mixed methods. And when we have an answer quantitatively that we can't fully explain, what qualitative methods can we use to supplement the gaps in our knowledge?
So the next question I'm going to ask about is carrying over from what you said. What are the field's methods and techniques and goals? And all of these panelists have advanced degrees. Rebecca's in a PhD program and has a Master of Public Health, and the other three are also attorney PhDs, two in economics. So what are the field's methods, techniques, and goals? And maybe start with Chris.
Sure. Well, I'll provide a little bit of a different perspective. In my view, health law and really law generally is about trying to manipulate behavior. We pass a law because we want someone to do something differently than they would have done in the counterfactual without the law. And we have lots of mechanisms for trying to do that, whether we think of it as deterrence or expressing a social value that people will shape their behavior in accordance with. But from that behavioral lens, if that's what we think of law as doing, then it opens up all the behavioral sciences to study it. And so I draw often from the tools of psychology and do, for example, randomized laboratory experiments to see how patients or physicians will behave when exposed to this information or that information, or exposed to information shaped this way or that way. And so psychology provides a toolkit, and it has since grown, especially in the fields of, we now talk about nudging or the behavioral sciences more generally. Some of those experimental methods have moved into economics and sociology and throughout the social sciences, and even into philosophy, where I originally got my training. There are some very interesting, in fact, my first empirical study was in a bioethics question of how people will respond to a request to donate their own organs. And it turns out that on the one hand, that could be viewed philosophically, but it's also a psychological question of whether someone will themselves sign that consent form. And so I think that'll answer your question most concisely, is to think about experiments, because they allow you to see the counterfactual of both what happens when you manipulate it one way and what happens when you manipulate the other way. And it allows, assuming you can use random assignment in the lab, it allows a really sharp focus on causation. Our weak spot is not necessarily causation as it is external validity or generalizability, is what we do in the lab applicable in the real world, because we can pretty much nail the causation question through the artificiality of the lab.
And Michael, same questions of empiric healthcare law and some of the techniques that you apply to it.
Right, and I'll pick up on really, I think where Chris was speaking a second ago. And in terms of, I think that the technique that you use particularly might depend on the question that you're going after. And so I think that it's hard to say. We're always using this particular technique. Even me as an economist, always using a particular technique. I think it depends on the context. What are we trying to illuminate? And before that, I want to think about, sort of a theoretical underpinning to the discussion as well. So there's a lot of work we have to do before getting to probably the empirical technique. But often what I'm sort of doing is very similar. I do a lot of program evaluation. I do a lot of, what's the effect of this particular legal structure on this particular outcome. And oftentimes, what I want to get at is to tell something of a causal story, as Chris was alluding to, not just coming up with metrics on a metric that's capturing the law and a metric that's capturing my particular outcome, and just seeing how they associate with each other. Ideally, I want to get a sense of how the law is actually affecting that particular outcome, which is helpful for policy analysis to the extent that what we could tweak out there is sort of the policy space. We want to get a sense of ultimately what's going to happen as a result of that. So causal inference is ultimately sort of important to me from a day-to-day basis. Where Chris and I probably, I would say where we're different in how we're actually doing our work is and it's not to say that. Not to say that sort of one way is necessarily better than the other way. They're just sort of different approaches. I'm often working more in a quasi-experimental space or natural experimental space, where I don't necessarily have true randomization, but without getting into the nitty-gritty, but I'm happy to get into the nitty-gritty, I'm also trying to create counterfactual environments to be able to sort of truly make these causal leaps. But I want to do so trying to sort of look at I want to look at the space out there, and can I see some institutional features in this landscape that will allow me to say, comparing this with this, and it's almost effectively random based on sort of what I know about this particular institutional or legal landscape. And so this is where I think this is a fun space to work in. It's a very challenging space. But ultimately, the idea is to try to come up with some method that will allow me to sort of, effectively say that this is close enough to random such that I can be able to go beyond just sort of, looking at an association between two numbers and actually make some sort of causal leap. I always stress that for my readers, I'm going to ask of you, you're always going to have to do some leap. My job is to try to make that as a manageable leap as possible. But I think but I think that there's still value added from this exercise, especially if we're dealing with a pressing policy problem. And theory is only going to get you so far. I think theory, as I emphasized earlier, needs to be sort of the underpinning of this entire discussion. But sometimes we're left with truly empirical questions, and these are important policy matters. We want to get as much information as we can as possible. And ultimately, I want to try to do the best job that I can to give you that information, but to be clear about sort of what assumptions you need to make to be able to sort of to really connect all the dots out there. And again, I just want to try to make those assumptions as palatable as possible. And so when I'm working in this particular space, I just have probably a different set of concerns than Chris does. In the laboratory space, you can do a much better job at getting randomization, but you might run into the generalizability concerns. Often you may have, the challenges are probably separate in the space that I work at. Maybe less concerned about generalizability. Sometimes you still have those concerns, but you're looking at what happens in the real world with some of these methods that I employ. But you have to, you really have a high burden in trying to really proving to people that what you have is effectively like a really good counterfactual out there. You really are kind of telling a causal story. And so you can think of, in terms of methodology, you can think of sort of what I do is if I just sort of plotted a particular relationship between two variables out there, to use an example from labor economics, not necessarily health economics. So on the one hand, I'm plotting schooling, and on the other hand, I'm sort of plotting income later in life. And you see a particular relationship there, and maybe I'm doing this because I'm trying to sort of tell you a particular story about the effects of schooling on income. Your hand's immediately going to pop up and be like, well, what about this? What about this? And a lot of it's going to be, you're going to have a lot of stories about unobserved variables in there. And so our goal as economists often is to come up with basically answers and responses to all of these what about this and what about that kind of questions.
And when the stars align, we get experiments that are run in the field. So, the Oregon Medicaid studies were an example of that, where, great for empiricists, not so great for the people of Oregon who need health care, but Medicaid and health in Oregon didn't have enough money to serve everyone, so they randomly assigned some people to Medicaid and some people with no coverage. And so we got to look to see, what kind of outcomes resulted from that. What sort of benefits do we get from Medicaid coverage in the short term right now, but there'll probably be longer term studies. That experiment is over. I think they ended it. But it was an example of an experiment that was done in the field where we can combine these two methods. And sometimes those are really a nice way to try to draw causal connections.
Yeah, I'll just add, it's truly great when that happens, and I guess you can make sort of much sort of stronger claims in those particular situations. And so I think it's fair to say that this might be the gold standard, sort of a methodological approach. The concern when I hear, we always want to hit the gold standard, it's for various sort of economic and political reasons. We just don't have as much experimentation as we economists would really like, true experimentation, true randomized experimentation. And so I don't want our efforts to stop to say, because we can never truly hit that gold standard. We have a lot of other techniques out there to try to get, again, it's about, these are really important policy questions. We want to try to get as much information as we can. So I sort of push back a little bit when I hear a lot of criticism of the quasi-experimental approaches. Again, if it might fall short of true randomization. But I still think there can be a lot of value added there, if done right and if done well, and if done with a lot of transparency. And so I think transparency is really important here.
How do you set up your collaborations? This type of research is, often one where you have to interact with people outside of the law school. And how do you go about doing those collaborations, getting people involved in the disciplines that would complement and augment your areas, and also get collaborators that have data for these natural experiments?
Well, sometimes, sometimes it's just over cocktails at an event like tonight. There'll probably be a collaboration that'll happen around 6:45 tonight. I don't know who, but someone in this room is going to generate an idea, and 5 years later they'll have the data from it. But literally, it's social networks. I think can't be underestimated here. Every now and then I'll cold call someone and say, hey, I have this data set I heard about, but I don't know how to get into it. Can you, you've got this fancy, data mining technique. Can I write you into this grant? So occasionally there's a cold call. We also exploit our own universities too, our natural networks. But I think so much of the fun part of it is actually finding an excuse to work with your friends.
Right. And then I wanted to ask each of you, who are the stakeholders and audiences for empiric healthcare law? How much of it is legislators that have the power to change laws based on new information or testing? Is it courts? Is it other researchers? Is it the media? Is it all of the above? And how do you manage those relationships? Do you look to establish those relationships?
I think the stakeholders and audiences, again, are quite wide. Certainly policymakers of all kinds. We don't necessarily like how they use our research in all cases, but they definitely put it to use. And I think other researchers, certainly, we learn from each other. We learn about data that's out there. We learn about methods that have been used. We recently joined together to work on a project because Mike had used methods in previous work that I really need for a project I'm working on. So we've just started to work on a project together. But I think also people in the industry, healthcare providers, healthcare insurance companies, they're certainly interested in what our research has to say about legal rules. And I think litigators as well, we're seeing the research we're doing being cited by the courts, which they're not citing usually on their own. It's brought to them by litigators. And so I think in all aspects, the work can be widely disseminated and used.
I would echo that. I think increasingly we're seeing empirical studies being used by courts, and I think even the Supreme Court. I think Stephen Breyer might be the justice that's doing so the most, not just in the health law field, but others, and that's wonderful. I think some of the challenge can be making the information accessible to people who don't have scientific training, and so one of the weaknesses of the field that have been acknowledged, I think back to, I remember a conference I attended, there's an empirical health law conference every year that Kathy and Michael run, and this was back in, I don't know, I guess it was 2008 or so, and it was when I was kind of inspired to join the field. But even back then, we were talking about how this translational piece, and that we're not doing enough to actually make the get the studies in the hands of policymakers, and let them know where there are areas that we don't have enough knowledge, but there are areas like medical malpractice where we actually do have a robust evidence base, and making sure that policymakers are aware of that and understand what we know and what they can do with that. And so I feel like we're still having these same conversations, and we've made some progress, but not as much as I think we could. And there are a number of ways I think we could do more. Increasingly, a number of faculty from Harvard that work over at the medical school are doing stints in government down in DC and in ASPE and some of the other agencies, and then going back and sort of that revolving door with academia. And I think that brings in some scientific expertise to the policymaking arena, and then and back and forth. I think increasingly translational personnel are situated within institutes and schools, so a designated person to actually get these who is experienced in both the science and PR, and to actually get these study results into the hands of media, policymakers, et cetera. I think creating, we're doing a better job of this, but outlets, so Twitter, blogs, and those sorts of things to actually get the information and do it, sort of dumb it down to make it actually palatable to the common lay reader. And then having meetings on mental health parity I attended. It was sort of what I thought we should always be doing. It was a meeting in DC that researchers from Johns Hopkins had organized, that was a meeting between academic researchers, and we talk to each other a lot, and I think that happens plenty, but it's the bridge between the researchers, the academic researchers, and the nonprofit practitioners, the governmental personnel, the people who wrote the mental health parity regs, and so have that institutional knowledge, and everybody getting together, and the sharing of that information, and hearing from people in the field who are fielding complaints from consumers about this is the way in which our mental health benefits are not being met. This is what we need, and then having that feedback loop to researchers, so we know we don't need to be researching this more. This is not helpful. This is what we need to do. We need to know. So having that conversation is so important, and doesn't, I think, happen enough. So.
Good. Well, let's turn now, because the panels has a lot of rich work that they can talk about. Let's ask some questions based on the panelists' individual work. And let's start with Kathy. Tell us about your current work on the impact of damage caps on medical malpractice insurance premiums, and also why you decided to do another study, and what are some of the questions that you didn't think current research had really answered.
Sure. So as of today, I think there are 16 studies that use regression analysis to try to estimate the impacts of damages caps, usually non-economic damages caps that compensate injured patients for pain and suffering damages. I am working on the 17th study, and so I need to do some work to justify, why this study is necessary. I got involved in it because I was invited to do a literature review of the studies, and to try to figure out what we know from these studies. What do they tell us? And then doing that literature review really opened up my eyes to really dive in there. I had read these studies, but to look at them collectively, I learned, and really evaluate them from a critical perspective, I learned three things. One, the results reported in them did not comport with the conventional wisdom. So the conventional wisdom is that caps work to reduce medical malpractice insurance premiums. And what I saw was just a bunch of mixed results. There were some that said yes and some that said no. And every single study except for one had mixed results within the study. And so that was really surprising to me when I looked deeply at it. I also noticed that the premiums, medical malpractice insurance premiums data that were being used in these studies were really less than ideal. The best data out there are just from surveys where we get kind of a selected sample of reported prices. And there's also a very limited range of specialties that we know about, doctor specialties, and policy limit sizes, which I think will be important for really trying to get at what's happening. And then the methods employed, I think, leave some open questions about the reliability of the results and sort of what inferences we can draw from them. So that literature review for me was a stepping off point. I'll confess that one of those 16 studies is my own from my dissertation, and I count myself in that critique. And so The first thing I wanted to try to do was collect a better data set of medical malpractice insurance premiums. And so that's what I started on. And it turns out to be really hard. And I've been working on it now for about 3 years. And we're hand coding a data set from insurance filings that insurance companies have to file with the state departments of insurance when they start selling new products. And so what we have right now are about 2 million observations of offers that insurance companies make to individual doctors of a variety of specialties, and also covering a variety of policy sizes. So just like auto insurance, doctors can pick policies that cover $1 million per occurrence or $500,000 per occurrence, down to $100,000 of per occurrence limits. So that was the phase one of the project, was just really getting a better data set. And then, as Mike said, it's really important to start with theory. And so the story that these researchers were examining seemed so simple. You reduce the spoils from litigation, medical malpractice insurance prices should go down. Right? That's the simple story, just looking at the litigation stage. But when we add to that the realities of the litigation, which is that policy limits, I've learned this from other research that I've done with other people, researchers, that policy limits can act as de facto caps on recovery. So even in cases where litigants get big jury awards, they often will recover only what the policy limits allow for. So rarely do doctors pay anything out of their own pockets, even when the awards or settlements the awards go beyond the policy limits. So patients seem to, for whatever reason, and there's limited data on this, but from what we can see, patients don't seem to be going after doctor assets. So policy limits have a big impact on what's recovered. And if policy limits tend to be, for doctors who buy small policies, we wouldn't expect non-economic damages caps of $1 million to have any impact on smaller policies. And so there can be variations across different types of doctors who buy different types of policies. And then if you think about how caps might impact physician choices over which treatments to provide, especially as we move now into a world away from fee-for-service and toward global budgeting or rewarding for reduction in costs, physicians are going to be looking for ways to reduce costs. And so that might mean skimping when they can. And if the stick of liability gets smaller, we might see shifts in physician treatment. And so until medical malpractice customary care standards catch up with that treatment, we might actually see more litigation. So maybe smaller average awards, but a higher number of cases. So the prediction about how non-economic damages caps impact prices of medical malpractice insurance is actually quite complicated. And so that's the project I'm currently working on. As I mentioned, I roped Mike into this project with me, and so hopefully we'll have some results to share from that study soon.
Right. Mike, you are studying a similar area, but from a different perspective, which is do the malpractice laws, tort laws, have the intended effect of reducing medical errors?
Right.
And what have you found about that?
Right, and so even more broadly, I've been interested in understanding how the medical liability system affects physician behavior, whether it sort of affects the intensity of their treatments or sort of the quality of the treatments that they administer. And thinking about how do we go, methodologically, and again, there are some particular theories that might guide how those predictions sort of play out. But going right into the methodologically, how do we actually sort of approach this? What's this relationship between the medical liability system and what physicians do? Well, there's been a couple of typical approaches. I would say that the classical approach that you see from a lot of papers is to sort of, it's related to what Kathy was just talking about. Well, let's see what happens when we basically take the system and sort of blunt its impact by doing something like adopting a cap on non-economic damages awards. And so if we thought that let's say that we thought that the system was otherwise inducing physicians to practice defensively and to sort of, to run up cost. So liability pressure is increasing the amount of spending that we're doing. Well, then you would predict that if you sort of cap liability, if you cap damages awards, that would reduce liability pressure, and maybe we'll see spending go down. And so one typical way of sort of evaluating this link is to draw on this, go back to my idea of natural experiments. Well, we have 50 different states out there, and they've adopted damage caps at different times. This creates a bit of a sort of a quasi-experimental space that we could sort of look at. And that's sort of a typical approach. And I've done some studies of this typical approach too. But I've actually tried to sort of push the literature beyond just focusing on the remedy side of things and to not overlook the substance of liability rules. And so when we talk about something like deterrence, and you ask your question in terms of deterrence, the idea of medical liability is in part to sort of improve healthcare quality and to deter medical errors. Well, when we talk about deterrence, and when I talk about this with my tort students, I spend a lot of time talking about the negligence standard. When Oliver Wendell Holmes talked about deterrence, he talked about the negligence standard. The idea is when you accidentally, for a physician, you accidentally harm somebody, you're not always liable for the damages that ensue. You're liable if you'd breached that particular standard. And so I thought that this was being underappreciated by sort of the empiricists in this area. And so one could sort of ask questions about, well, is the standard of care really empirically relevant? Are physicians actually, to the extent that it's there and there's liability consequences associated with failing to comply with the standard, is that incentivizing physicians to try to live up to the standard? And so a lot of my work has been sort of guided by that particular question. And so methodologically, quasi-experimentally, how have I approached this? Well, obviously I needed to go out there and find some variation in what the standard is. So to do any empirical analysis, often you need some variation to correlate something with this, and then obviously I try to go beyond correlation and again make that leap towards causation. You need some fluctuations. So where am I going to get fluctuation out there in the negligence standard? And so here I actually sort of relied on a couple of things, and one is, and I think many of us who've taken first-year torts, depending on the casebook you use, you may have been exposed to this. There was a sort of a fundamental shift over time in how we, in the U.S., how we did formulate the negligence standard in the context of medical malpractice. And that had to do with sort of the shift from a locality rule to a national standard rule. And this was basically, with medical malpractice, we really defer to custom and what physicians customarily do as the standard. So it's kind of a real self-regulatory approach towards sort of tort liability. But there was initially, what was that custom? It was the local custom, what physicians were doing around you. And over time, what you saw is states at different periods of time sort of moving towards away from that and having sort of no longer having geographic limitations on what this sort of customary standard is, effectively moving towards national standards. What is the standard that you're expected to live up to, physicians, is what is sort of customarily done by physicians across the nation. So ultimately, there was a shift in sort of how we formulated the negligence standard out there. And I sort of rely on something that Ina mentioned earlier. There's a lot of literature out there, a lot being promulgated by Dartmouth, but even even before Dartmouth, other scholars have talked a lot about this. Geography seems to matter a lot in terms of what physicians do. Physicians in different regions do very different things. They practice medicine very differently. And so in light of that sort of significant background that we know about sort of the medical landscape, geography really seems to matter. This geographic distinction in medical malpractice law really is potentially quite relevant. And so if we're talking about a particular healthcare environment in Mississippi before '85 when it operated under a locality rule, and the law says, well, all you need to do to avoid liability is what physicians in your local Mississippi community are doing. All of a sudden, we shift that, and so now the standard that's going to apply to you as a physician at court is going to be what physicians are doing at large. In light of the fact that Mississippi physicians may be doing something very different from physicians elsewhere in the country, that's a real meaningful change in the standard that's going to be expected of you at court. And so what I was basically doing is, well, did we see physician practices change in light of those altered expectations? And the fact that I was able to sort of get similar changes across a bunch of different states at different periods of time, I was able to construct, without getting into the details, basically sort of a nice experimental framework. It's not true randomization, but the goal was to sort of to nonetheless use similar techniques that we would do if this was sort of a true randomized sort of experiment and see what results that we get. And then a lot of additional work that I have to go into and look for a particular mark. If I thought that there was look for a bunch of markers that basically suggest, you know what, this is close enough to randomization that this is actually helpful exercise. So a lot of work that sort of goes into this. But I think that describes some of my studies to date. And Matt Frank, one of my co-authors of one of these papers, is currently a student here at Harvard, was helpful on one of these projects.
Good. Now, let's turn to Chris. Chris, tell us a little about your work studying conflicts of interest, disclosures, and their influence on doctors and patients.
Sure. And so with conflicts of interest, just an example of conflicts of interest that arise in two domains in healthcare. One is that the drug and device industry funds the vast majority of the biomedical science that tests the efficacy of their own products. We also know that in Massachusetts, for example, over a quarter of physicians take money from the drug and device industry sort of on the side. In addition to whatever they're paid in their clinical practices, they have various side deals with Pfizer or other companies. And we know this from one of my studies. It's just a descriptive study where we looked at the Massachusetts Sunshine Act, the mandatory disclosures, to just see what types of money were physicians taking, what percentage of them were taking money. And that alone took over a year to do because the data set, the way it was collected by the state, was not in a way that was amenable to actually being analyzed as data. So this is an instance where health law itself creates data that then has to actually be analyzed if it's going to be useful. And that's both analyzed by investigators for our aggregate purposes, but you might also think, well, who's the audience of this data collection? Is it ultimately to get to consumers? And if so, how will they access the data set? And you can think about usability and searchability and individual capacity of people at different educational levels to make sense of it, which then raises really behavioral questions about what do we expect them to do with this data, and how does it ultimately serve our policy goal? Will it shape their consumption preferences or their choice of a physician, or upon choosing a physician, will the fact that it's disclosed that the physician took money from the drug company, will that then cause the patient to decline the prescription? Or if they take the prescription, will they be less likely to adhere to the prescription? Is failing to adhere a good thing or is it a bad thing? Often failure to adhere to a prescribed drug regimen can actually increase the risk of say, a cardiovascular effect. So one of the things that I learned from doing empirical research is it just forces you to be a lot more clear about even what your policy prescriptions are supposed to do and how they're supposed to work. It forces us to be much more clear about those sort of causal mechanisms at each step. And sometimes it will be 10 or 15 behavioral steps that are mediating between getting to the health outcome that you're hoping for. So with disclosures in particular, for example, disclosures are just one mechanism we can use for managing a conflict of interest. Alternatively, for example, as a matter of law, we could prescribe the interest altogether. You could make it illegal to have a deal with the drug industry. Alternatively, you can say, well, it's all right to have the deal, but you have to disclose it. Well, then disclose it how? Is putting it on a website sufficient, or do you have to get the information directly to patients? So one of our major studies was to look at how physicians, as the consumers of biomedical science, how they think about a disclosure that the industry funded their own study versus, say, the NIH funding it. So here we did a randomized experiment with physicians reviewing biomedical journal abstracts in which we manipulated the methodological quality of the abstract, whether it's a big study or a small one, whether it used health outcomes or proxies, whether it was blinded or open label, all 10 different criteria for what you'd think is a strong study versus a weak one. But then we also manipulated the funding source, whether it was an NIH-funded study or an industry-funded study or no disclosure at all. And the reason we did no disclosure at all is because that's still the practice that most journals use, at least on the abstract itself. They actually don't disclose the funding source. So one of the neat things about an experiment that allows you to do is it allows you to test a policy that doesn't yet exist.
Right.
Which is great, because when you think about so much of our legal work, there's almost always a normative gradient to it. Like the bottom line of your typical law review article is we need to start disclosing, or we need to this or that. But often, to the extent that it's a new intervention, we have no way to test it except in a laboratory setting, ex ante, prospectively. So we found, surprisingly, in the study that when physicians learn that a biomedical journal abstract was funded by industry, they trust it dramatically less than when it's funded by the NIH. And so this was a much bigger effect than we hypothesized. And when we published this paper in the New England Journal of Medicine, the editor ran an editorial on it. And usually an editorial in the New England Journal, when it accompanies an article, is to sort of draw your attention to the article, say, hey, this is an important one, people. This should change clinical practice. But instead, the editorial for ours said, trust the numbers. Don't worry about the fact that most of the science published in our journal is industry funded. Trust us, we did a good job peer reviewing it. It was sort of a worry that physicians might in fact be overreacting to the disclosure. And so that really then begs larger questions about what's the right level of skepticism you should have about industry funded research, and that requires a lot of background knowledge about, well, how many discretionary decisions are baked into a study at what point? You know, what is the really economy of influence that led to that research finding? So I'll just allude to, we're now doing a field experiment with patients receiving disclosures that their physicians have financial relationships with the drug and device industry. And we just now have preliminary data, and I'll say it is a field experiment but the intervention here is a light intervention. It's just a letter being sent. But in the world of disclosure, that is the policy intervention we're interested in. So we're looking to see in this clinical setting whether it makes any difference. But even persuading a major academic medical center to do that intervention, including allowing us to have a true control condition that didn't receive the disclosures, raises all sorts of interesting issues around research ethics. Because if you think the disclosure was required for autonomy interests, for example, as investigators, I've nonetheless denied patients from receiving that disclosure to create the counterfactual to be able to test against. So I'll stop there.
Thank you. Rebecca, I'm going to ask you two questions that are related topically that you've studied. One is what happened or happens when mental health coverage and services are expanded to achieve parity? And also, what have been some of the effects on policies designed to decrease inappropriate opioid consumption? Because obviously that's another critical issue, public health issue, and issue that's been in the news recently.
Sure. Yeah, so the common thread of my research thus far is that it focuses on behavioral health interventions and laws specifically. And what I really like doing is identifying areas where there's variation in laws across jurisdictions and trying to get a handle on characterizing those laws really carefully, thinking about which are robust, which aren't, and then incorporating that into an empirical analysis. Part of what drove me actually into this field was a feeling that especially non-lawyers approaching this and thinking about laws as an intervention or exposure often thought of it as a binary, like does a jurisdiction have a law or do they not, as opposed to this law really has teeth, it has implementation funding, it is enforced, and all these sorts of features that from a hypothesis-driven thinking makes us think that it would actually have an effect. So that's sort of what motivated me into this area. Another motivation in the parity area was, this under-access of mental health care being a huge, actually, public health issue also in this country, although the study we worked on is sort of your bread and butter health services research type of study. So that study looked at the latest iteration of a long slew of parity laws, which require equity in insurance coverage between mental health and physical health benefits. And they've traditionally been in the commercial health insurance sphere, but they're actually being rolled out into the Medicaid and some other public programs under the Affordable Care Act. So the idea is that actually, this dates back to the seminal randomized controlled trial study in this field, which was the Rand Health Insurance Experiment, which showed that for mental health benefits, the price elasticity of demand is greater than that for physical health benefits. So that means that when you expand insurance benefits, people take advantage of that, and then it raises the question of, how much of this care is necessary versus not. And all of this history drove insurers to not want to cover mental health and substance use disorder benefits generously. And so we've seen this evolution of a disparity in terms of coverage. And at the same time, 1 in 5 adult Americans experience a mental health illness at some point during their adult lives. And we know, there's a lot of evidence that people just aren't receiving those services as much as they do for diabetes or heart disease or whatever medical condition you pick. So this latest federal law was actually designed to close a lot of the gaps in a series of state laws that preceded it. Particularly, it focused on administrative services only or ERISA governed plans that were not previously subject or governed by the state laws, but also close some of the gaps. And the idea was we want to have a uniform law in this area, and it's that important. So this is where thinking about it from a lawyer's perspective was important, because the challenge with such a comprehensive federal law was how do we do what Michael was talking about, which is create a counterfactual and create a good control group that we can say was not exposed versus everybody who seems to be exposed to this latest federal law. So there I did a look back to all the preceding state laws and decided to exploit an exemption that was in the federal law and in about half of the preceding state laws, which was that small employers were actually not subject to these laws. So there I created a peer control group over the study period, and then used some sort of fancy matching techniques to try to make the groups as comparable as possible, because my treatment or exposure group was these large employer plans. So the idea behind it, though, at the end of the day, was to see, does this expansion of coverage actually make a difference to consumers? Does it mean that as a consumer I face less in out-of-pocket costs when I go for my outpatient mental health visit? Does it mean that I'm accessing those visits more? Does it mean that I'm maybe using inpatient or emergency department care less because I'm actually accessing care on the front end? These were some of the hypotheses that we were working under. We found that, doing a number of different specifications, a number of different models, that at the end of the day, our results are actually quite similar to a lot of the predecessor state policy studies. And that suggests that these policies do modestly decrease out-of-pocket spending among consumers. Actually, we saw a little more movement on the utilization side. So we actually saw people obtaining more services, about 4% more in the first year after the federal law, about 6% more in the second year after the federal law, on average. And those were more, greater in magnitude and significance for people like high utilizers and high spenders, which was one of the goals of the law. And we need to do more thinking around these subgroups and who might be benefiting. But on average, it still is quite a modest result. So this is where I was talking about the qualitative supplement of understanding why are we not finding bigger effects? So is it because there are still loopholes that insurers are taking advantage of? They're still using managed care techniques, even though they're not allowed to under the federal law, but it's really hard to have oversight over those. Or is it simply because there are other barriers to accessing mental health care that are not addressed by this type of a law? And so that's part of where sort of some of the normative thinking comes in, sort of what should we do to advance the field to get people accessing their care more? Is our parity law sufficient, or do we need to actually go beyond this and address stigma, mental health provider undercoverage, care coordination, some of the other barriers that we know are persistent? So that's that study, and there's a lot of future directions that I think that literature and those studies can take. In terms of the opioid addiction, my focus is on prescription drug monitoring programs. The challenge in this space is that there are so many laws and policies at the state, federal, and local, and also non-governmental levels going on. And so separating out what combination of policies or specific policies are having the biggest effects is really challenging from a methodological standpoint. So I decided to focus on prescription drug monitoring programs because they're touted as sort of one of the most promising innovations in this space. And they are these state centralized databases that collect dispensing information at the state level, aggregates it all, and then makes that information available to prescribers, pharmacists, and often law enforcement officials. So the idea is we have this great centralized database that any prescriber could access and could look up when a patient presents, especially think of an emergency department doc who doesn't know this patient, has never seen them before, and they can access this database and see if the patient has, in fact, been filling these addictive substances, particularly opioids, and or has any maybe polypharmacy concerns. They're having opioids with benzodiazepines at the same time, which is particularly lethal combination. So it's this great database that could be used. The challenge is, are they actually being used? And so here I've focused on mandates that prescribers actually have to check the systems. About 6 or 7 jurisdictions have adopted these strong policy lever, along with having robust programs generally. And so the data analysis is still ongoing, but we're trying to parse out, does this particular policy feature, is this a game changer? Is this something that other states should really consider adopting? And other states are thinking about it. And so, but the medical community is actually has very strong opinions about this, because doctors don't like to be told that they have to do anything, let alone putting extra burdens on them, and they're already demanding careers. So, and in terms of delivering patient care. So the idea is, if we can get a good handle on carefully characterizing the policies and saying, these features actually are making a difference. They're increasing use of these databases, and they're also reducing some of these risky opioid prescribing. So in high morphine milligram equivalent dosages, co-prescribing that's dangerous, prescribing multiple providers and pharmacies over a short period of time. Some of these things that have been identified as high-risk prescribing, if it's actually budging the needle on those outcomes, then that's further justification that we actually can use law, and should use law to actually improve the public's health and have an impact here.
So before we go to the Q&A, the last question is, what is the most important contribution that the Petrie Flom Center and its affiliates have made so far regarding empiric health law, and where could the center have the biggest impact moving forward? So just go down the line. Who'd like to start? Chris, do you want to start?
I'm going to think for another minute about the biggest impact. That's a challenging one.
I think in terms of sort of in the recent years in particular, and having academic fellows like Chris and Michael and faculty fellows like Kathy, there are a number of student fellows who have been involved in empirical health law projects. So I think the portfolio is increasing in terms of its adoption of empirical health law projects, but I do think that the center could expand its work in this field, in particular maybe by adopting some center-wide projects that have strong empirical components, and working with either empiricists at the law school or elsewhere to really build out that portfolio.
Good. Kathy?
So in terms of what the center has done, it's really been a champion of empirical health law, one of the major forces in the field, including this topic in the conference was a really nice thing for the field. Inviting empiricists to come and speak, to give workshops to students, to expose students to the work is really useful. And to get us together to talk to one another is really useful. I think anytime we get together, we talk, we have cocktails, and then some project is born. And so just getting us together is a really good idea. In terms of moving forward, I think the center could make big impacts in terms of data. So more and more data is coming online. The government is putting more and more data online, and it's really great. There's a dearth of sort of legal data, and so because of that, what we get is recreation of the wheel often. And so I think, and this is a little bit of self-interested suggestion, but I think funding for data collection is really important. So I am getting support from a law and economics center at a different university to collect the premiums data set. And I'm required to post it to make it publicly available, which I think is great. So it's going to eventually be a public resource that everybody can have access to eventually. And so I think that not only the funding of, but having a repository for these data sets would be a great step forward. And then also there's, as far as I know, and maybe correct me if I'm wrong up here, but I don't think there's any catalog out there of data sets that are available that pertain to health. So I would love to be able to click on a page and just see a list by category of the data sets that are out there with links to, which is just a nice place for us to go and sort of look what's out there. I don't think anyone's doing that, and I think it would be a really nice way to just help researchers figure out what's out there and save us some time and effort. So those are just a couple ideas.
Good.
Yeah, I mean, I think that when running a center, one of the things you want to do is bring a lot of people into it, especially people from different disciplines. And Glenn and Holly are already doing like a fabulous job on that. So I think kudos to you guys. In terms of data could always be sort of an element to that equation. I've thought about this and institutional. We've had discussions about this at Northwestern, kind of create a new health center there. Well, data can be sort of a catalyst as a way to sort of get people together. Certain types of researchers, they love their data. I love my data, right? And so you might want to. So it can be sort of a device to sort of bring people in. But obviously, sometimes data could be accessed so easily remotely now that it may sort of, if your goal is to bring people together into a common physical space, we might need to think a little more creatively just about sort of using data, but to still try to achieve getting people actually sort of physically together. Where as like Chris is kind of alluding to earlier, just collaborations can happen at that point. Just the exchange of ideas can happen at that point. Yeah, I do think that there could be. I do think there's a need for some sort of data repository. It's probably in the health law space right now. So whether this is of interest to Petrie Flom Center, I don't know, but certainly something to think about. In terms of sort of moving forward, I would just, in terms of to the extent that something like a particular center wants to get involved with sort of sort of producing new empirical scholarship, just sort of my words of caution is that there are just so many important policy questions out there, and you might be sort of tempted to want to have to say something about everything. But empirical projects are really difficult, and they take an absolute ton of time. I'm doing a project right now on sort of the military health system that has been in the works for years. And part of it was, a lot of that was sort of the data collection. And to do all of this convincingly, you really need to invest the time, and you really can't sort of, there's not a lot of shortcuts there that you can often sort of really take advantage of. And so I guess I would just sort of be mindful of, try not to sort of bite off more than you could really sort of chew. And so it would be great. I sort of see this as just being sort of a collective scholarly and academic exercise. And there's so many important questions out there that we need answers to. And to be, you don't want to have a free rider problem where like, you don't want to take what I'm saying and be like, well, why bother at all? But I think that to the extent that all of us here can sort of get more involved in these efforts, to the extent that the center can get more involved in these efforts, I think that that's great. But not to lose sight of the fact that to some extent you have to sort of tackle, and Chris is kind of alluding to that too. Sometimes you have to sort of tackle sort of like one mechanism at a time, one question at a time, and to do that well requires a lot of work. But we still need to do it, basically.
And maybe I'll be a little bit imperialist about empiricism and say that it's all empiricism in this way, that one thing the Petrie Flom Center has done for health law is really just raise everybody's game. Even when we see a paper that doesn't have any data itself that comes and is workshopped here, sometimes the most important criticisms the author gets is, isn't that third point you're making really an empirical claim? Aren't you really claiming something about how people will respond to the disclosures, or whether they can bear the cost sharing, or whether physicians will change their behavior or not? Because so often, sort of the all-too-easy legal scholarship or the all-too-easy policy advocacy just involves a lot of hand-waving. And so at the bare minimum, what the Petrie Flom Center has done is raised everybody's game to just be more rigorous about the arguments we're making, and to be more careful. And sometimes that's just about calling out that there is an empirical study that needs to be done and isn't being done. And until it is, we perhaps need to be a little more humble about the policy mechanisms we are arguing for or raising. And so that's in a sense in which all legal scholarship, to the extent that it's normative, to the extent that it's engaged in the real world, is begging big empirical questions, and we all are better scholars when we are aware of that. And I think that's something that's infused in the culture of the Petrie-Flom Center, whether it's from the student fellows or the faculty workshops or the academic fellows, is that sort of carefulness and that sort of humility. And so I think building more in those traditions is definitely the right way further forward, even if it's not doing empirical work per se. It's having that empirical humility to care about whether a policy really works or not, whether it achieves its goal or not. And that's all we're trying to do, is find a way to measure that.
Well, let's have some questions from the audience, and as usual, queue up behind the mic. I think we have about 15 minutes for questions, and
I'll sneak one in before Kristen gets to the. And this is, so you've all been excellent teachers for me as being consumers of empirical data, and I'm kind of curious your pet peeves about the translation into the public sphere. So my top two sins would be over-reliance on p-values to the exclusion of effect size and failure to use multiple testing penalties. But I'm kind of curious whether you have actually others that you think, especially in the translation into the public sphere, you see these things happening over and over again. If you wish that good consumers of this data would think about this more, how you'd fill that in.
I just say, wow, I'm proud of you, Glenn. You picked on two of my biggest sort of pet peeves as well.
Osmosis.
Yeah, I know. And again, I just completely agree. And I see this with a lot of sort of my peers in sort of law and economics academy. Just so much of a focus on just, I found a statistically significant effect. I found a statistically significant effect. Like, okay, well, how big of an effect? Say a little bit more. And it's you're like, what methods really sort of produce that? As some people in this room know, I bug people all the time about sort of multiple hypothesis testing sort of penalties. And so I think that. Those are sort of two of my pet peeves. If you sort of read a lot of my work with sort of co-authors, with Melissa and Matt's in the room as well. I like to see a lot of transparency. I like to see a lot of robustness. I like to see a lot of flexibility. If somebody is really sort of modeling something as a linear relationship, and that's like a pretty strong assumption to assume it's linear. There's a lot of techniques out there to have a much more flexible approach to estimating things. I like to see flexibility. I like to see a lot of sort of sensitivity analysis and robustness analysis, and just and really try to beat up your own work before sort of present it to me. That's sort of a kind of a big catch-all sort of pet peeve.
My two. So those are good, and I also agree with you. My two are citing to a single study. So cherry picking from the literature. Advocates do this all the time. It's a terrible advocacy move, because someone on the other side is going to find those other studies, but we see it all the time. So people make claims from single studies when there are entire literatures out there that might tell a different story. And then also the inability to distinguish quality. So I think right now we're in the middle of a crisis with non-peer-reviewed law journals publishing papers by lots of people, including law professors who go to 2-week camps during the summer and learn how to use statistical packages. And so there's just a lot of bad stuff out there. So really not being able to distinguish the good stuff from the not so good stuff is one of the big problem.
Yeah, I think following up on that, people in my department have actually been giving lectures to media to try to educate a little bit more on the science, but the amount that media are picking up on studies and that are very clear in their terminology about association, and then the headline is totally causal, and there's no distinguishing between, what are we learning about the possible relationships versus we can ascribe these outcomes to this law or this policy, and that goes to sort of a hierarchy of research designs and what is appropriate, what type of research and what type of design is appropriate for what conclusions, basically.
And I'll take this opportunity to plug my new book. Just came out last month. It's called Blinding as a Solution to Bias. It's edited with Aaron Kesselheim. And this is, I guess, would qualify as one of my main concerns is that we are in the social sciences and applied sciences like law are only beginning to learn the lessons that the biomedical sciences are still themselves learning, but at least they're 40 or 50 years ahead of us, in really worrying about any time there's human discretion involved in the process of science. Is the scientist able to even accidentally bias their results? So one way this can happen is through statisticians doing data mining, for example, repeatedly selecting which subset of their data they're going to use for a hypothesis test and which way they're going to model it. If they're doing that with an eye for reaching a result, they can find a result. We see this in litigation science, for example. You can hire, if you're going to test whether a data set shows employment discrimination, the plaintiffs can hire a statistician and the defendants can hire a statistician. And what do you know? They each reach results that are favorable to their side because it's possible to mine the data in a way to reach that. A solution for that, on the other hand, is to construct your models in a pre-specified way before you've even seen the data set, which effectively blinds you in selecting your models and selecting your exclusion criteria and your inclusion criteria. We're not doing nearly a good enough job in that sort of thing. But also in the social sciences, when we're, for example, coding states, does this state have policy X or policy Y? How often is that coding being done by people who also have a stake in the outcome as to whether it's coded one way or the other? Sometimes it's completely objective. I'm not worried about bias. But quite often, when you poke just a little further, that coding decision itself was a tough call on the margin. And again, it's best that's done by an RA who doesn't even know what your hypothesis is. And then that it's double and triple checked, and we check for the reliability across those coders. Again, basic things they've been doing for some time in the other sciences. We need to get our game up in this field.
Good. Well, we have time for 2 more questions and 2 people in line.
So I was interested to see a couple weeks ago a proposed rule released under Medicare Part B, a controversial proposed rule changing the way that cancer drugs were going to be reimbursed. And I read down the press release a couple of paragraphs, and it said that actually the policy was going to be implemented on a geographic basis. So some of the areas are going to retain the old compensation mechanism, and some areas are going to be going to a new compensation mechanism. And so I was wondering, it was interesting to see this, right? So experimentation from the very beginning, but it's in a payment policy setting. And I was wondering if you had any thoughts about whether that could be extended to other types of law or policy settings and how that might be done.
Yeah, absolutely. I think, the first question I would ask about that particular one is how did they choose which, did they randomize? So I would want to know, right?
The press release didn't say.
I read it 3 times looking for that. It doesn't say.
It would be good if it was randomized, right? And so randomization is great because you hope that all of the other characteristics that might be impacting outcomes are even equally distributed across, the units that end up in the control group and the treatment group. So I think, this is one of the areas where we could really do some good work, but it's incredibly difficult. So in my perfect world, I would love to randomize, doctors who get the benefits of non-economic damages caps and doctors who don't get the benefits of, but of course we can't do that. So there are, to the extent we can do it, we should try to do it. We should try to get involved from the beginning in these sorts of things. The Veterans Administration has done Department of Veterans Administration has done some really good work in this area. They have done randomization. in different areas to see how things work. And then once they see, wow, it's having a great impact, then all of the VA hospitals get treated. So we've seen great success in this in terms of policy, trying to figure out how policies impact outcomes. I think we could do more of it, but of course there are serious limitations to what we can accomplish.
And one thing to think about is where there are quasi-laws, where you have a hospital that is functioning as a unit that can be treated as if a law applies, or a military base would be another one where you could impose a speed limit, for example, if you're interested in speed limits effects on health, on half of the military bases. Or so other domains like a disclosure mandate, you can roll that out to individual patients. So thinking more about the unit of randomization can be at the patient level or at the base level or at the state level. You can also randomize across time. Even if you're just going to pass one law that applies nationwide, if you roll it out in 6-month intervals in different parts of the country, again, it depends on how that law is administered, what those units might be. Some laws are actually administered at the level of the federal circuit. So there's lots of opportunities there. I'll mention that the federal government has created a particular group that started in the White House and has moved over to the General Services Administration called the Social Behavioral Sciences Team. And they have the explicit mandate of performing randomized field experiments in the federal government and then rigorously evaluating them. And so one they've done in the health space, for example, is just sending out, is anyone on this team here, just sending out letters to physicians that appear to have abnormal prescribing behaviors to suggest that, we've noticed and this might become a false claims problem for you. Just sending the letter that we've noticed you're an outlier to see whether that causes physicians to sort of roll back and not become outliers anymore. Again, easy to do in randomized design because it's just a letter, but that alone took several years of preparation to do that.
Last question.
So I guess this is a question about qualifications and process, and in some response, it's some regards, it's a response to one of your comments, Catherine, which is to say, several years ago, I heard somebody say at a conference, if you're interested in law and economics, don't bother if you don't have a PhD in economics because Posner already did it. And so I'm wondering to some extent whether the same thing is true in health law, and if you don't have a PhD in some sort of, stats-based discipline or economics or what have you, then there's no real point in getting involved because all you're going to turn out is kind of crappy 2-week summer program scholarship.
I think we need to adopt the model that medicine has started long ago, where physicians were your biomedical scientists, and they would partner with biostatisticians, and they'd just write them into grants. Now more and more physicians also have PhDs in there, but I don't think that's necessarily a requirement. The physician knows the clinical reality they're trying to treat, and has an understanding of the causal mechanisms, at the cellular level that they're trying to influence. And similarly, lawyers have a deep understanding, if they're good, of exactly what the intervention is and how it's supposed to work. And so then partnering with a statistician, I think, can be perfectly feasible. A little side note also, on the other hand, is doing randomized experiments can require less fancy statistics as well, because you're controlling for all the reasons you use fancy statistics. If you can to control for and try to reach causation, you can instead, if you can just manipulate people and force them to be equal, to be matched in each arm, then you may not need the fancy statistics if everything goes well.
Great. Well, I want to thank the panel, and it's been a terrific discussion. I know the audience really appreciated it, and thank you very much. It's been great to be a part of this.
Thank you.